Hello everyone, welcome back to Comment Made Easy, and I hope you all are doing very well. Before we begin, let me remind my dear students that the contents of this channel are only to supplement your knowledge, not to replace the regular online and offline classes in your institution. So please attend your classes and do not miss them. Also, if you like our contents, please subscribe to our YouTube channel, like the videos and share these videos with your friends, with your batchmates, with your juniors. Also, if you are a teacher, then with your students. Please follow our Facebook page and the link will be given in the description. We have finally arrived to a point where we can discuss the clinical management of dengue, which includes the management of dengue fever, dengue hemorrhagic fever grade 1, 2, 3 and 4. If you remember that we discussed in our previous video, the grade 3 and grade 4 of dengue hemorrhagic fever is also known as the dengue shock syndrome. The management of dengue fever includes management which is symptomatic and supportive. During the acute phase, bed rest is advisable, and to keep the temperature below 38.5 degrees Celsius, we recommend cold or tepid sponging frequently. Antibiotics like paracetamol can be used to reduce the body temperature, but aspirins and NSAIDs like ibuprofen etc. must be avoided because it causes gastritis, vomiting, acidosis, platelet dysfunction, and it can also lead to severe bleeding. Now, paracetamol is preferred for fever and the dose is given here. For pediatric, generally speaking, we prefer to give paracetamol in the dose of 15 mg per kg body weight per dose, and for adult 500 mg per dose. We must not use the combination of paracetamol with the above mentioned drugs like the NSAIDs that we mentioned here. Also aspirin. Now, in case of any fluid loss from fever and vomiting, we encourage the patient to take plenty of fluid orally. Small amounts of oral fluids should be given frequently for those patients who have nausea and anorexia, because large amount of fluid may not be tolerable for them. What are the different fluids that can be taken? We can give fruit juices, coconut water, rice water, barley water, oral rehydration solution and soup. And fluids like commercial carbonated drinks like cold drinks, as well as those drinks which are not isotonic or above the level of isotonic, that is 5% sugar, should be avoided. Sufficient oral fluid intake should result in frequent urine output, at least 4 to 6 times per day. Patients should be monitored for next 24 to 48 hours to see whether they have become afebrile, that means there is no fever, and whether there is any complication developing. We have to remember certain key points like warning signs develop from day 3 to day 7. And increased capillary permeability causing plasma leakage is the main pathophysiology during the critical phase. A rising hematocrit is the earliest sign of plasma leakage. So all these features must be taken care of or considered, and these are very important. Now, in which situations a patient needs admission? So different admission criteria. If there is any warning sign, for example, persistent high-grade fever that is 38.5 degrees Celsius and above, any other warning signs including sudden drop of temperature, that is hypothermia, or if there is any sign symptoms related to hypotension, possible plasma leakage, and the signs and symptoms include dehydration. The patient cannot tolerate oral fluids. That is why the patient has to be admitted for intravenous therapy. If there is any dizziness or postural hypotension, profuse perspiration, that means lot of sweating, fainting, prostration during defervescence, hypotension or cold extremities, difficulty in breathing, shortness of breath, that is deep sighing breaths, if these are all present. If there is any bleeding in the form of spontaneous bleeding and independent of platelet count. So irrespective of the platelet count, if there is any spontaneous bleeding, the patient has to be admitted. Also, because of organ hypoperfusion, there can be organ impairment. So there can be renal, hepatic, neurological or cardiac impairment. We can have enlarged tender liver, hepatomegaly. though not yet in shock. Chest pain or respiratory distress can be there because of pleural effusion. There can also be cyanosis. If we get certain findings through different investigations like rise in hematocrit, if there is pleural effusion or ascites as found in chest X-ray or ultrasound, asymptomatic gallbladder thickening because of gallbladder edema, etc. Coexisting morbidities like pregnancies, and diabetes mellitus, hypertension, peptic ulcer disease, hemolytic anemias, etc. If present, the patient should be admitted. Overweight or obese patients, where it is quite difficult to access the vein very rapidly, in that case the patient should be admitted. Also infants and old age patients, that is the elderly patients, should be admitted. Certain social circumstances include if the patient is living alone or if he is living far from the health facility, if there is no reliable means of transport. So in case of any emergency, there is no guarantee that the patient can be taken to the nearest hospital immediately. In that case, the patient should be admitted to the hospital. So these are all the admission criteria. Next, we are going to talk about the management in dengue hemorrhagic fever grade 1, 2, 3 and 4. We discussed about this grading in details in our first video, if I remember. But just to summarize, in dengue hemorrhagic fever grade 1, we have dengue fever, along with that positive tunicate test and plasma leakage, sign of plasma leakage. In DHF 2, we have all this in DHF 1 plus spontaneous bleeding. In dengue hemorrhagic fever grade 3, we have all the features of DHF 1 and 2, along with that circulatory failure. And there is profound shock along with the other features in DHF 4. So these are the grades. What about the management of dengue hemorrhagic fever grade 1 and grade 2? Any person who has dengue fever along with thrombocytopenia, high hemo concentration, that means the hematocrit level has increased. And also there is presence of abdominal pain, there is black tarry stools, epistaxis, bleeding from gums, etc. So hemorrhagic manifestations. These patients need to be hospitalized immediately. And they should be observed for any signs of shock. Rise of hemoconcentration, or you can say hematocrit, indicates plasma leakage and loss of volume, for which it is needed that the fluid management should be initiated as early as possible. So intravenous fluid is important. So this is the algorithm for management of DHF 1 and 2. As you can see, we have to look for any hemorrhagic tendencies, thrombocytopenia, that is the drop in platelet count, and rise in hematocrit. So these patients we have to start with IV therapy, intravenous therapy with crystalloid solution, ideally 0.9% normal saline or ringal lactate. The initial dose is 6 ml per kg body weight per hour, which is given for 1 to 2 hours. If there is improvement, we decrease this rate from 6 ml per kg per hour to 3 ml per kg per hour. On further improvement, after 24 hours, we discontinue the IV fluid. Now, if there is no initial improvement, then we increase this rate from 6 to 10 ml per kg per hour for next 2 hours. Same, the crystalloid is being given. This may lead to improvement. So we decrease from 10 to 6, then 6 to 3, and then we discontinue, just like on the left hand side. But if there is no improvement, we look at the hematocrit level. If the hematocrit is still rising, we have to give intravenous colloid in the form of dextran and the rate is 10 ml per kg per hour for 1 hour. If the hematocrit value falls, that means the hydration is adequate, but still the hematocrit is falling, which may indicate certain internal hemorrhage. And in that case, we may have to give blood transfusion, and the rate is 10 ml per kg per hour. So after this, there may be improvement, and then we go back to the crystalloid solution from 10 ml to 6 ml per kg, then 6 ml to 3 ml per kg per hour. So just like this one. And then we discontinue after 24 to 48 hours. When we say improvement, we actually mean, you can see in this flow chart, there are a lot of places we have mentioned improvement or no improvement. or unstable vital signs. So what do they actually mean? Improvement means hematocrit falls, pulse rate and blood pressure are stable, and urine output rises. Whereas no improvement means hematocrit or the pulse rate remains high, pulse pressure falls below 20 millimeter of mercury, and urine output does not increase. So it falls or it remains very low. Unstable vital signs means urine output is low, as well as there are signs of shock. So this is the algorithm for management of dengue hemorrhagic fever grade 1 and grade 2. What about grade 3 and grade 4? Now, despite the treatment as if the patient develops fall in blood pressure, so the blood pressure goes even further or even lower, and there is decrease in urine output, and there are features of shock, in that case the management of grade 3, grade 4 dengue hemorrhagic fever should be started. However, in case of persistent shock, even after initial fluid replacement and resuscitation with plasma or plasma expander, if the hematocrit continues to decline, we have to suspect bleeding. If you remember, you already mentioned this here also in case of DHF grade 1 and grade 2, and we can suspect hemorrhage, internal hemorrhage, and we have to initiate on blood transfusion. Okay, so what is the algorithm here? So we have unstable vital signs where the urine output is low, there are signs of shock, there is hypotension, so BP is low, less than 90 millimeter of systolic blood pressure, reduced blood pressure, pulse pressure, as well as high hematocrit value. The patient must be given oxygen therapy. It is important. Immediate rapid volume replacement. We start with crystalloid, but the rate is 20 ml per kg, and it is given as bolus over 15 minutes. So as you can see here, high amount of crystalloid solution is given as bolus in a duration of only 15 minutes. If there is improvement in vital signs and the hematocrit level falls, we decrease the the crystalloid solution, and the rate is decreased from 20 to 10, and then 10 to 6, and then 6 to 3, just like the previous algorithm, if you remember, ml per kg per hour. And on further improvement, after 24 hours, we discontinue the intravenous therapy. So we start with 20. Upon improvement, we reduce from 20 to 10, from 10 to 6, from 6 to 3, and then discontinue it after 24 hours. If there is no improvement, then we have to repeat the bolus dose over next 15 minutes. So we do the same thing here. We repeat 20 ml per kg crystalloid bolus over next 15 minutes. If the hematocrit rises or more than 45, in that case we have to shift to colloid. IV colloid, we can give dextran 40 or hemaxil or plasma, etc. And the rate is 10 ml per kg per hour as intravenous bolus over 30 minutes. So if the crystalloid bolus even on repetition does not work and the hematocrit keeps on rising, then we have to give colloid, and the rate is 10 ml per kg per hour. It is also given as bolus for next 30 minutes. If the hematocrit falls, we can suspect bleeding, and if you remember, if you suspect bleeding, we have to give blood transfusion at the rate of 10 ml per kg per hour, same as the previous management. In case of improvement of vital signs, we have to start intravenous therapy. We have to shift to the crystalloid, and we have to reduce the dose from 10 ml per kg to 6, then 6 to 3 ml per kg per hour, and after 24 to 48 hours, if everything is stable, then we can discontinue the intravenous therapy. But if there is refractory hypotension even after blood transfusion and there is no improvement in vital signs, then intravenous inotropes with crystalloid is to be given. Now the question is when to start and stop intravenous therapy. In febrile phase, we generally do not advise intravenous fluid. It is not needed. So it is to be limited. If we give early intravenous therapy, it may lead to fluid overload, especially if we use non-isotonic intravenous fluids. But in critical phase, intravenous fluid is often required for 24 to 48 hours, depending on the stage and the hydration status of the patient. Now, patient who present with shock, intravenous therapy should be for less than 48 hours. During recovery phase, if you remember from the pathophysiology video, there is reabsorption of the fluid into the circulatory system. Because of that, if we also continue the intravenous fluid therapy, that may lead to volume overload. So you have to be very cautious about that, because it may lead to heart failure. That is also very dangerous for the patient. What type of intravenous fluid should be used? We should use isotonic solutions like normal saline, 0.9% normal saline, or ringer lactate. Colloids are preferred if blood pressure has to be restored urgently. So dextran, Cimaxil, etc. can be used. What are the different colloids given and when it is given? Okay, so when the colloids are given, we can give it in case of hypotensive shock, repeated shock, that is second or third shock and onwards, after more than 20 to 30 ml per kg of crystalloid. So when crystalloid have been given but still the condition is not improving, we may need to shift to the colloids. If the hematocrit does not decrease after crystalloid administration in shock stage. So we have already mentioned this thing, and the dose is limited to 30 to 50 ml per kg per day. Okay. What intravenous fluid should not be used? That is another question. Hypotonic solutions, for example, 0.45% saline, which is the half of 0.9% normal saline, should be avoided even during the febrile phase. Dextrose solution should be limited to avoid hyperglycemia, but may be used in hypoglycemia with closed blood glucose monitoring. So if the blood sugar of the patient goes down, then dextrose can be given, but you have to keep on monitoring his blood sugar level. And albumin solutions should be avoided. So this is all about the different types of intravenous fluids, what fluid should be used, what fluid should not be used, and when to use colloid, etc. How much and how fast the intravenous fluid should be given? The minimum intravenous fluid required to maintain good perfusion and urine output is about 0.5 ml per kg per hour. So this is the minimum dose or minimum rate at which the fluid should be given. Now the volume of the fluid which is to be given is based on the ideal body weight if the person is overweight. And we have to titrate the dose based on the hemodynamic status of the person, also based on the age of the patient. When we say titration of intravenous fluid rate of hemodynamically state person, that means we have to reassess the hemodynamic responses immediately after the IV bolus stage. After the shock is corrected, we have to reduce the intravenous fluid in stepwise manner. So we cannot drastically stop the intravenous infusion, that is very risky. So from 10 ml per kg to we reduce to 6 ml per kg, then to 3 ml per kg, and then we stop it. So it is to be reduced in stepwise manner. If the patient is hemodynamically stable, it can be stopped, or if the rate of plasma leakage decreases towards end of critical phase as indicated by improving hemodynamic signs, increasing urine output, adequate oral fluid intake, so the person can take fluid orally, or hematocrit decreases below baseline value in a stable patient. So if all these signs are present, then we can discontinue the intravenous therapy. Just to summarize the IV fluid therapy in a dengue patient. If the IV fluid therapy is inadequate, it will lead to hypovolemia because there is already plasma leakage. And this may lead to compensated shock leading to hypotensive shock, and there can be associated bleeding, disseminated intravascular coagulation, and multi-organ failure. If the hydration or intravenous fluid therapy is adequate, it will improve the circulation and the tissue perfusion. The capillary refill time will be less than 2 seconds. The heart rate, the blood pressure, the pulse pressure, everything will be normal. Urine output will be 0.5 ml per kg per hour or more. The hematocrit will decrease to the baseline given the age of the person, and also there is improved acid base condition of the patient. But if the intravenous therapy is excessive, that will lead to fluid overload, especially during the recovery phase when there is reabsorption of the extravascular fluid into the circulatory system. If we continue the intravascular fluid therapy, there will be excess of fluid in the circulation that will lead to fluid overload, and this is featured as pulmonary edema leading to respiratory distress. The pleural effusion and the ascites can even worsen further, and there is clinical deterioration of the patient. What are the indication of platelet transfusion? We often have this idea that a dengue patient needs platelet transfusion almost always. We often see that the platelet count has gone down, and we suspect that maybe we need to give the patient platelet transfusion, but it is not so. Not all the patients always need platelet transfusion. So what are the different indications? It is never the mainstay of treatment in a case of dengue fever. In general, even if the platelet count goes below 40,000 per cubic millimeter, there is no indication of prophylactic platelet transfusion. So the patient does not need platelet transfusion. If there is any hemorrhage or bleeding manifestation, irrespective of the platelet count, the patient needs platelet transfusion. Also, even if there is no hemorrhage, but the platelet count has gone lower than 10,000 per cubic millimeter, even in that case, the patient needs platelet transfusion. So just to summarize again, if the platelet count is less than 10,000, it does not matter whether there is any hemorrhagic manifestation or not, the person still needs platelet transfusion. Also, if there is any hemorrhagic manifestation, irrespective of the platelet count, the person needs platelet transfusion. Along with that, if there is prolonged shock with coagulopathy and abnormal coagulogram, so the prothrombin time, APTT, CTBT, we have to look for those, and in that case, the patient may need platelet transfusion. In case of systemic bleeding, platelet transfusion may be needed in addition to red cell transfusion. Alright, remember, whole blood transfusion or whole fresh blood transfusion does not have any role in management of thrombocytopenia. So there is no point of giving whole blood in case of thrombocytopenia. We just have to give the platelet. Okay. Now coming to the indication of blood transfusion. So when do we need to give blood transfusion? If there is loss of blood, which is 10% or more than the total blood volume for the person. If there is refractory shock despite adequate fluid administration and declining hematocrit. So we have given the crystalloids, the colloids, and still the hematocrit keeps on declining. In that case, we may suspect internal hemorrhage and we may have to give blood transfusion. The replacement volume, that means the blood transfusion, should be 10 ml per kg body weight, and coagulogram should also be done. If fluid overload is present, packed cell transfusion is to be given. Use of whole blood, fresh frozen plasma or FFP, and cryoprecipitate is to be done in case of coagulopathy with bleeding as per advice of the treating physician and the patient's condition. So not all the patients need whole blood or FFP or cryoprecipitate. If there is bleeding, then the treating physician will decide whether he needs these components. What about the discharge criteria? So on what ground or in which situation we can finally discharge a patient who was admitted? So the admitted patients who have recovered from acute dengue infections with visible clinical improvements. So how can we know whether there is any clinical improvement? There will be no fever for at least 24 to 48 hours. So 1 to 2 days, no fever. Blood pressure is normal. There is no respiratory distress from pleural effusion or even there is no ascites. Improvement in the clinical status like general well-being, return of appetite, adequate urine output, and no respiratory distress. The platelet count is persistently above 50,000 per cubic millimeter. In all these cases, if all these are present in the person, then the patient can be discharged from hospital. So this is about the discharge criteria. So with this we conclude the whole discussion on dengue. We have so far discussed the different clinical features of dengue, and also the pathophysiology behind all these clinical features, the diagnosis of dengue, as well as different investigations that is needed in a patient, and then how to manage a case of dengue fever or dengue hemorrhagic fever grade 1, 2, 3 and 4. So if you like the video, please subscribe to our channel and share this video with your batchmates, juniors and friends. And also we have a Facebook page that you can follow. The link is given in the description. Take care and we shall see you in our next video.